I think we're doing it. We're going to do another one of these. This time I'm going to also share this video to YouTube. I downloaded the last video and I wasn't able to embed the video into an email because the file was too large. So I think this time I'm just going to record it here. So it's saved under the training teams folder, but then I'm also going to just put it on YouTube and then share the YouTube link so people can watch it. Same thing as last time. I didn't quite get the turnout that I thought I was going to. I'm not too sure how to make adjustments to make it more incentivizing for people to tune in or listen or even make these themselves. If they don't want to just listen to me, I'm more than happy to incorporate other people's training material and their insight. But for now, I'm going to just maybe say one or two numbers like I did before and just kind of ask for that as the verification or the attestation that you listened to the whole thing. I'm kind of winging this one a little bit, similar to the last one, because it's pearls of wisdom time. So it's like tidbits. Dr. Stein does this. I started doing it after I saw a couple of hers. I realized that I was writing so much in the body of the email that perhaps it got lost in translation, or reading's tough, or it makes people sleepy. I don't know, but we're going to keep doing this for now. I have a handful of things that I definitely want to go over. I'm going to try to be succinct about it. I'm going to try to hit each one. A lot of it, or a couple of the things, are protocol updates. And then a couple of critical care things, a couple of EMT basic things, a couple of AEMT things, so I'll hit the whole spectrum, and I'm trying to tie it all together. So tie the EMT concepts all the way up to critical care, and then tie the critical care concepts into how can the EMTs understand this and then provide their support, under their scope of practice. So, and my kitty's being annoying again. Come on, Snowball. So I guess we'll start with the meat and potatoes of the protocol update, which is CPAP for the EMT. Let me see, where is it? Here it is. I'm just going to read the protocol. Spontaneously breathing patient in moderate to severe respiratory distress due to congestive heart failure, pulmonary edema, asthma, COPD, pneumonia, drowning, or undifferentiated respiratory distress, concurrent with the following signs and symptoms: oxygen saturation less than 94, retractions or accessory muscle use, adult respiratory rate of greater than 25. First and foremost, about these, if somebody's a COPDer and their oxygen is normally 88 to 92, that person's oxygen saturation may be 84 to 86%. And you would consider that with CPAP, but maybe a COPD or somebody that has chronic CO2 retention who lives at 88 to 92%, and they can definitively tell you that that's the range that they live at. Maybe they present with respiratory distress and their oxygen is 91%. So I'm not saying don't do CPAP for those patients. A lot of them still benefit from CPAP. But that's a little, the point of that is this number is not 100%. It doesn't necessarily always have to be below 94%. A COPD may be sitting at 93%. And according to this, so you have to use a little bit of critical thinking with all of these patients in all aspects of the protocol. You can't just, my fear is the lack, and this is not meant to sound, I don't want to undermine or demean or suggest that EMTs aren't a capable assistants. They're not capable workers and healthcare providers. But I just think that patient exposure, the number of patients you see, and then when you start to get into the critical care paramedic side of things, I think that the amount of time dedicated towards understanding the pathophysiology and then kind of all the things surrounding CPAP help contribute to the knowledge of when to apply it, how to make titrations when things aren't 100% according to protocol, which none of the cases we review are really ever black and white cases. They're all because something veered to the left and the right, and then we had to change something. And then you say, was that change correct? And if it's not, you do a case review, you learn about it, and then you try to apply that new knowledge going forward. And then if you did do it correctly, you then take the information and you explain to other people why. So either you learn and everybody learns, or you did it correctly because you've learned before, and then you teach everybody, and then everybody else learns. And the concept behind the principle is a shared kind of mental model, which I talked about last time, and a shared understanding. If you have 10 people in a room that all talk about a case together, and 8 of them will do the same thing, but 2 of them wouldn't, maybe we have to figure out why the 2 people didn't do it the same way, and then how do those 2 people fit with the other 8 people. And then in the very rare circumstances, maybe 8 people did do it wrong and the 2 people did it correctly. So this right here is kind of vague. There's a lot of patients that don't have COPD, asthma, reactive airway disease, drowning, pneumonia. I'd say even like smoke inhalation, probably too, heart failure, pulmonary edema. There's a lot of patients that don't have these conditions that also would present like this. So then your question is, according to this protocol, should I apply CPAP or BiPAP to the patient, even though they don't have asthma or pulmonary edema or CHF? So, an example that I'll talk about often is DKA. DKA patients breathe really fast, and sometimes they're profoundly ill and hypotensive. So therefore, they may not saturate well oxygen-wise. They may have accessory muscle use because they're fatigued and acidotic, and they certainly will have a rate above 25, even if they're an adult. So those patients, according to this, meet the following signs and symptoms for the protocol, but they don't meet a condition that requires CPAP. So my fear is that there will either be a lack of skill and people will be nervous, so CPAP will be underdone, or it will be overanalyzed and too many people will be CPAP'd who maybe don't need to be CPAP'd. I would say, by and large, my opinion is that too little people are CPAP'd now, even by paramedics and critical care paramedics. So then, I want to swing the pendulum towards CPAPing more people, but I don't want to swing it so far to where we apply CPAP to a DKA patient just because they're breathing fast. And then obviously it's contraindicated in pediatric patients that have a new scope of practice. So can't maintain their own airway, vomiting, GI bleed. You can induce nausea, vomiting by applying CPAP. The amount of pressure that goes in, if it's too much, some of it will almost surely go into the stomach. And then if the stomach distends, then there's a chance that distension induces nausea and vomiting. Cardiac or respiratory arrest or apnea, I mean, that's the biggest contraindication. Respiratory stress secondary to trauma, that would be because you'd be suspecting some sort of pneumothorax or tension physiology, or maybe an injury to the great vessels or the cardiac structures, and you wouldn't want to add pressure to the injury. And then right there it says suspicion of a pneumothorax. Facial trauma within possible face seal. One thing to note is that there should be a mask leak no matter what. There shouldn't be an excessive leak, because then one of 2 things will happen. You won't actually be providing enough pressure to your patient, and then you'll run out of oxygen really quickly because you'll just be bleeding oxygen free flowing through the CPAP mask. If you're transporting somebody in a facility, for example, you might run out of oxygen. So you definitely want to have a tight seal, but it can't be 100% airtight, because if you trap all the air in, then you could maybe cause barotrauma, but certain amount of air has to escape in order for the patient to successfully breathe in and out and not feel suffocated. Can't follow commands, agitated, combative behavior, hypotension when the MAP grade less than 60 or systolic less than 90. There is some, know that the patient is, I'm not telling you not to follow protocol, but if you know that the patient has a COPD or one of these conditions, and all of these things are met, so they need CPAP, your alternatives are to bag the patient, put them on CPAP, and try to coach them through it and hope that it works if they're still spontaneously breathing enough, even if they're altered a little bit. You might still be able to successfully use CPAP. So I don't really consider, it's a relative contraindication. So yeah, use it cautiously, but your alternatives are to wait until they lose responsiveness, and then they'll be in respiratory arrest and you have to intubate them. So you need enough oxygen. You need to explain the procedure to the patient. I find that a lot of the times people who quote unquote don't tolerate CPAP is because maybe the pressure is too much, the mask seal is too tight and they feel suffocated, or the mask seal is too loose and they're not getting enough oxygen. So then now they have the same respiratory distress as before, but now they have this thing on their face. And a lot of the times the mask isn't actually applied correctly. It's leaning off to the side, it's pinching something. I mean, imagine a continuous stimulus to your face and you're saying, hey, relax, relax. I'm the expert. You're not the expert. I'm the expert. And then you attribute the fact that you didn't apply the CPAP mask correctly, you attribute that to the patient not tolerating it. That means that your inability to make the mask more comfortable then got misrepresented as patient unable to tolerate, and then a treatment was omitted because the mask seal could have been better, but you didn't recognize it. So please be cautious of that. I mean, it literally takes time and dedication. And I mean, you're on scene, you're in the back of the ambulance, you are waiting. And if you really, really need somebody else's help and you struggle with doing it, just hold the mask to their face while you figure everything else out, because then they're going to be getting the positive pressure. And it takes time for recruitment in the lungs to build up. And you certainly don't want to, the longer you wait, the harder it is to develop that, to obtain that recruitment. Adjust pressure to 5 to 15. Honestly, I've never used 15. I mean, maybe with BiPAP, when you have the PEEP with the inspiratory pressure, it might be like 12 to 16. But I mean, 15 is a lot of pressure. I would almost certainly say 5 to 10, but like 5 for almost everybody. Maybe not a drowning patient. You know, they might be able to tolerate a little bit more, and CHF patients can tolerate a little bit more as long as they're not borderline hypotensive. The straps, we just need to get better about fitting masks appropriately the first time so we don't waste supplies and then we don't de-recruit or have air leaks or have a mask that's too small and then it's uncomfortable. So try to get the mask to fit appropriately the first time, and then really just pay attention to the straps. Hair and sweat and the patient's positioning. I mean, and then there's a whole protocol, and Dr. Wolfson talks about it, I think, a little bit too in one of his YouTube videos about patient positioning. It's underdone. It's simply underdone, and people don't pay enough attention to it. So all these basic concepts add on top of each other, and then through repeated exposure of patients that have these conditions, you get better at it. And I think that's what separates advanced level providers from EMT basics. Not to say that there aren't EMT basics that have better assessment skills than some critical care medics, because that could be true. But I mean, don't be scared to apply these interventions, but also understand that the more you do it, the better you'll get. And don't be afraid to learn and do things better next time. Because if you're scared to learn and then, or you're scared of getting in trouble, then you're not really going to acknowledge your mistakes. This stuff is hard and it takes a ton of time and dedication to get it right. So I encourage all the EMTs and AEMTs and paramedics to do more research about what lung recruitment is, what the pressure actually does. Because when you put CPAP on somebody, you actually change the internal dynamic of their thoracic cavity. They were previously breathing with negative pressure, which actually really isn't. I mean, the thing was, the diaphragm moves down and then air goes in. And then you replaced that with pushing air against the diaphragm, which adds pressure, increases the pressure in the thoracic cavity. And then the more you do that with too high a pressure, it could cause, a decrease in cardiac output. It can cause compression of the great vessels, which makes it harder for the heart to press against those. And, so if you apply CPAP to somebody or BiPAP to somebody and they get more tachycardic and their oxygen doesn't improve, then maybe you got to do something different. And that's a huge topic that I'm trying to circle back on all the time. Like, if something's not working, you have to do something else, because here's the deal. Either, and this is a tough thing to balance, and it comes with experience. If a patient's not getting better on an intervention, you either haven't given them enough time, the intervention you're applying is suboptimal. So maybe in this case, instead of 5 centimeters of water, they need 10. Or the intervention's wrong. And the extreme examples that I give are never just wait 20 seconds to see if somebody feels better. That might not be enough time. But also 30 minutes and they're not getting better, you've probably missed the boat. So how do we dial it in to find like this common ground where we're like, okay, I've given it 5 to 10 minutes, it's not working, but I know I'm on the right pathway? Add another treatment. Okay. Increase the PEEP. What else can you do? Inhaled duonabs. I know the protocol says to do it every 5 minutes, but like theoretically, every 5 minutes for a neb. That's almost, if you do 3 in a row over 15 minutes, that's quasi stacked neb therapy. Research that if you're on your own if you want to. But the benefits of doing continuous are sometimes a lot better. Sometimes it's what patients need. You know, they maybe don't need just one, but multiple. And then also things like magnesium, sometimes anxiolytics, sometimes IM epi, honestly. And I think EMTs and AEMTs should be aware of that. You never know in the spectrum of somebody's illness where you're going to find them. So just limiting yourself to the tunnel vision of CPAP by itself is a little bit dangerous. Not dangerous, but it's just, you know, there's a lot more than just CPAP. And I think that's what people need to start working on, is just doing their own research and asking questions, find mentors and stuff, you know, like this. I hope the culture of learning and changes, because I think there's room to grow even with really busy critical care paramedic services. And I just think that people have either have a fear, or they just don't really have the desire. You know, they don't want to bring their own faults to attention, but then I don't know. So whatever it is, I think by and large across the board, everybody could do better with reviewing runs and then talking with their partners about it at a minimum, to say like, hey, what would you have done in this instance? Or did you agree with this? And if not, why? And then if you are lucky enough to have 6 to 10 people in a room and you can review all, I mean, tough to do 100% QA, QI, but if you can review all of your calls with at least all the calls with sick people, and then you can find out what everybody would have done, that goes a long way. Yeah, you can consider using a BVM with PEEP. I see PEEP valves not applied to BVMs all the time. Call for paramedic intercept if not available. Call for EMT intercept. This right here is hugely important. You don't overestimate your own ability because you're applying CPAP. And so that is a good intervention. It's great that EMTs are doing it. And then also, if you're a paramedic and you do all this other stuff but don't apply CPAP, kind of shame on you as well, because you should be applying CPAP. Like, you shouldn't be skipping, you know, if you fix somebody's SpO2 and now they're 92, 93% and they're a COPD, or so that's okay for their range, and then you put them on end-tidal and their respiratory rate is still 40 and they still have an increased work of breathing, you can see like belly breathing, or, you know, they're still sitting forward, or they can't talk to you very well. You really just fixed one number. You didn't even fix it. You just changed it. It's not fixed because you don't know what their cellular SaO2 is doing without a blood gas. So you really didn't fix anything. You really just made their SpO2 go from 86 to 92%. So it looks like you did the right thing in terms of your vital signs upload, but not all the way, because the respiratory rate is still 40. So it's like you tried an albuterol, and then you like gave Dex or Solumedrol, and then you didn't do CPAP. That's weird to me. I think, like I said before, CPAP is important, more than people probably do it. So I really think that all CPAP patients should have a paramedic, because we can do something more comfortable for them, which is change the CPAP to BiPAP. So if you do a good job in like 10, 15, 20 minutes, however long it takes for the paramedic to get there, if you do a good job developing lung recruitment and the patient improves, then that assessment finding goes a long way with it when a paramedic gets on scene, because then they know that you're doing the correct algorithm. So all they should have to do is adjuncts at that point. You know, if they haven't done inline nebs with a little T-piece. So you just take the T-piece. It's just a little blue thing with one side's a 15 and one side's a 22 millimeter adapter. It goes in between the hose and the mask. And then the bottom, which has a one-way valve in it, you put the albuterol canister from an albuterol med mask or a pipe mask, and then you apply that. You set that to a secondary oxygen source, 6 to 8 liters or something like that. And that's all it is. Inline nebs, hugely important. I don't know why people don't do them much. It's a little bit of extra work, but I mean, seriously, do the research if you want to. These patients have fewer ICU days, and sometimes you can prevent them from being intubated altogether. You might even prevent them from going into the ICU. They might be downgraded from high flow and then like an oximizer in the ER before they even get admitted. Congratulations, you saved an ICU bed for a septic patient, a DKA patient, or some sort of cardiac patient or a stroke patient. So, anyways, that's kind of all about this. With really bad emphysema patients who have fragile. Also, I recommend everybody watch some sort of simple video, one that you can actually digest. You have to do a YouTube search. Understand the difference between constrictive airway and restrictive problems. Compliance and restrictive problems. With COPD, understand the difference. And then if you're critical care, please do more research on, there's crap, I should have posted some videos. Watch some detailed videos about airway compliance, the mean airway pressure, because the mean airway pressure is the actual pressure that's like being delivered and measured at the capillary level. And you could give somebody all the FiO2 you want, but until that pressure gradient is somewhere between 7 and 12 centimeters of water, right? Which is why we apply the CPAP 5 to 15, is to push it across. And if there's more resistance from, I don't know, asthma, or there's like ARDS or pneumonia, and there's a gradient issue, so there's like actual things between the capillary alveolar membrane, then you might need more than just 7 to 12 of pressure. And then, so when a paramedic gets on board, hopefully they will take your CPAP and change it to BiPAP. One, the patient will tolerate it a little bit better. It's a little bit nicer. You more closely match the normal chest physiology, ventilation in, the pressure. And it's just nicer on the patient. So, people don't need 25 over 10. That's ridiculous. That might cause barotrauma, but people probably need 12 over 6, 10 over 5, 8 over 4. You might have to play with it a little. And like if somebody can't breathe out, if you're noticing that they're breathing in, but they're not doing a full breath out, so you notice that there's some space for an air leak, but you're not actually feeling anything there, then maybe back off on the total pressure going inside the patient, because maybe they just can't breathe forcefully enough against it. And it could be because they're just super tired because they've been working to breathe for so long. You take a healthy person and then you do like their maximum exhalation force against a tube. Like most people can do it, or most healthy people that aren't in the hospital can use an incentive spirometer and make the ball go all the way up. But if you're sick and you've been breathing 40 times a minute for 2 days, maybe you just don't have the energy to breathe against that much pressure. So you might have to go down a little bit. I mean, even if you put them on BiPAP, like 7 over 3, that's still their intrinsic PEEP plus 3. And then the total inspiratory pressure is 10 plus whatever they're doing on their own. So it could be 12. So 7 over 3 sounds minuscule, but for some patients, it might work. And EMTs can't do it for pediatric patients, but for pediatric patients, you certainly want to be on the lower side. We're talking like 3 to 6 for the inspiratory pressure. So that's that. Continuous positive airway pressure. A's will do, maybe A's could do IM epi in the case of impending respiratory arrest. Oh, see, maximum of 5 for pediatric patients in the EMT scope of practice. Yep, that makes sense. You should put them on capnography. Don't worry about the quote unquote air leak by having them on a nasal cannula end tidal. That is not really, it's more beneficial to have the end tidal than it is to not put it on and have a maybe 1% better seal. Likewise, an inline end tidal may be inaccurate because of the amount of space between the mouth, and it's not really a closed circuit like an endotracheal tube is. There's an air leak. Like a 20 liter per minute air leak around the side is honestly probably normal. So that's a lot of oxygen, that's a lot of air coming out, and you will probably not get an accurate inline end tidal reading. I think paramedics should always be there because, and that's interesting. It talks about interstitial syndrome. So it's really interstitial lung disease, consolidation, or ARDS, maybe. And then medical direction orders only. Okay, so for medical direction, consider an anxiolytic, you have to call medical direction. Yep, 2.5 IV IM, so it's half the dose. We don't really carry Valium. Administer benzos and caution in patients with hypercarbia. So I don't know if anybody's ever seen a hypercarbic patient that have PaCO2s of like 100 to 120. They're extremely altered and usually end up getting intubated. And then if their end tidal is 100 or their PaCO2 is 100, and then you give them a benzo, which slows their respiratory rate, their PaCO2 will get higher and they may lose the ability to protect their airway. So you shouldn't give somebody, I would, if you're going to give somebody an anxiolytic, it might be better to develop some recruitment and hopefully get the end tidal down a little bit, because we can't really measure, and like we don't have the eye stats. So end tidal is really the only way. And your end tidal reading might not be what the true PaCO2 is, but you can at least trend it. If you put an end tidal cannula on somebody and then it starts at 60, then goes to 50, then goes to like 44, they're not really that hypercapnic anymore, or you've improved it at least. Maybe consider a benzo there if they still show signs of anxiety. But a lot of people's anxiety will get better just by reducing the amount of carbon dioxide in their body and just by improving their respiratory rate and addressing their hypoxia. Because, like, newsflash, hypoxia causes anxiety. It's this crazy concept. So that's it. I think that's really all I wanted to talk about. I just quickly Googled some CPAP. David sent out some stuff. I mean, and then the space between, let me find somebody who's sideways. A lot of these masks have like there's like a piece here that comes out, so you can adjust how far away from the forehead it is. It should be like an inch over the eyebrows relatively, maybe a couple. All of that is extremely important. Oh, and you can move it up and down. That stuff's important. So that's really it. I don't really think we have the ability to do much pediatric CPAP at the A paramedic level with the mask sizes we have. Small mask, maybe. But when you get down to like a 4-year-old, 4-year-olds have really bad asthma sometimes. They would benefit from CPAP, but we might not have a mask that fits them, which means you'd have to bag them. If they're alert enough where you could sit them up and do it, that would be good, because then you can do an inhaled bronchodilator with it. You obviously can't do it when they're laying down because the liquid would just dump into the face mask, but that patient should be bagged. If your patient does lose consciousness and you're doing CPAP and your seal is good, like your mask fitting is appropriate, you should just, if they're pulling their own respiratory, and some of the new machines like the Zols, that we have, the Z-Vents, you can see how much tidal volume they're pulling. Sometimes because there's a leak, it might do their tidal volume in addition to the tidal volume pulled by the monitor, it might add them together, I guess. So you might see patients with tidal volumes of like 2,000 to 3,000 milliliters. It's not actually how much oxygen is going in their lungs. It's just that the circuit is combining breaths or combining the patients with multiple breaths, and sometimes it just appears as though they're breathing 2,000 to 3,000. But if your tidal volume is showing up as like 1 or 200, then the patient's not breathing deeply enough. Then you have to use a bag valve mask. But my point is just leave the mask on them. That's like, it's working, it's tight, the seal's good. Bag a patient with a BVM over the mask you already put on. Because if they wake up and they start doing better, you can just put them back on CPAP without having to take the head straps off. All right, that's that. Diabetic emergencies. Sorry, let me minimize this. Hyperglycemia. I have had a couple of DKA patients that have taken up TVM recently. I think these patients by and large are very, very volume depleted. We're not really doing the fluid restriction because of the shortage anymore, but this was always a patient population that never applied to because they're so volume depleted. Some patients require like 10 liters of fluid in a day. It's crazy. You give them like 4 or 6 liters and they're still not making much urine. Or they're still very tachycardic or hypotensive. The critical care paramedic stuff that I want to talk about with this is that electrolytes are super important. Fluid status is very important. Fluid boluses are very important. Insulin is very important, and insulin titration and hourly glucose checks are very important. And then if the patient's glucose gets below like 200 to 300, switching them to a dextrose containing maintenance fluid so that they don't become hypoglycemic is very important. Patients remain on the DKA protocol until it's not just their sugar. They don't come off insulin when their sugar is below 200 or something. That's one of the parameters, according to the CVMC anyways. Their sugar, you need more than 2 readings in a row. So if it's 200, then 400, then 200, doesn't count. You start it over. It's got to be multiple in a row where the sugar is serially less than 200, but that's just one. Also, their anion gap has to be normal again, so below 12, and then their bicarb has to be going back up, which means their base deficit has to be going in the right direction as well, and their pH can't be, I don't know, definitely not below 7.2, but ideally it would be above 7.3. All of that, and their electrolytes have to be fixed. So like that's when patients come off the DKA protocol. So you may have patients with blood sugars of 80 to 140 that still have an anion gap acidosis. Their pH is still 7.15. Their bicarb is still 10, and their base deficit is like -9. So those patients need to remain on insulin and get electrolytes and fluid replenished as they go, which means they need dextrose, because if you don't give them dextrose, then the insulin continuously will cause them to be hypoglycemic, and then you'll have to give D50. And we don't want to give D50 because that will cause rebound hyperglycemia. Okay, I have a part of the critical care guidelines that I have been working on. Let's see where the DKAs is. 7.2. Oh no. Okay, insulin, saline, NS, glucose checks. This explains that you need all of those parameters to be fixed. And then don't drop the sugar more than 100 an hour. So we're making insulin titrations. And then I made a chart somewhere. And this is just copying the adult chart. Oh, here it is from Central Vermont Medical Center. So I'm going to go through this bit by bit. This is what we want, 60 to 126 per hour. So, 60 to 100 an hour. Just kind of remember that range, just like your normal glucose, which is 60 to 100 for adults. CVMC, MAR insulin instructions. So this is for the average adult patient with DKA that doesn't have a specific DKA protocol based off like an intensivist. If a physician prescribes a particular DKA that's not this, then you should obviously listen to that. That's true with a lot of pediatric patients. Sometimes nephrology teams might get involved if the patient is very complicated. Anywho's, so they pretty much, if the patient sugar is above 300, they are getting LR, and then insulin based off their body weight. Well, I don't have the chart here. So it's based off their body weight. I think it's like 0.1 or 0.01 units per kg per ml, or per minute or per hour. I don't remember, but it's based off their body weight, their actual body weight. And then as soon as the sugar gets below 300, you switch the LR to D5 half normal saline. This is to maintain a pH neutrality, as well as to offset the chance of hypoglycemia induced by insulin with a lower blood sugars. And then pediatric patients based off PICU specific or sending order. I guess if you have no order to go on, yeah, you shouldn't be transporting that patient, honestly. So if your blood sugar is greater than 300 and you get any rise from the previous, increase insulin by 3. Any fall from less than 51, increase by 2. Fall in 51 to 60, increase by 1. Fall 61 to 125, which is what the goal is. Oh, this is 126, whatever. No change to infusion. Fall greater than 125, decrease by 25% and notify the provider. Then as soon as you get into this range, and really it seems complicated, but it's not. You just say, this was the sugar, this is now the sugar. Which range am I in? Am I here? Am I here? Am I here? And then what was the difference between the last reading and this reading? That's all you need to do. So let's say you get a sugar that's 200 and the previous sugar was 250. It's in this range because it's 200. 200 to 250 is a 50-point decrease, which is less than 51. You make no change to the infusion. Let's do another example. Let's say your sugar was 246 and now it's 176. So that's a decrease in 70. And now you're in this range because the sugar is 176. So it's a decrease in 70, which falls in here. You decrease the infusion by 50%. Let's do one where the sugar goes up. Let's say your BHGL was 90, and now it's back up to 199. So now you go 90 to 199 is an increase of 99. And we're in this range now. Any increase your infusion by 2 units. That's it. And then if BGL is less than this, stop the infusion and then follow your dextrose instructions for hypoglycemia protocol. Do not increase insulin to 30 units an hour or higher without provider approval. And then here's the instructions for D50 and then what to do and then how to start the insulin again. Right here, let's see. So pretty much if their sugar at the next check and their gap is still open, their pH is still bad, their bicarb is still low, and let's say they go back up to 100, you just restart. Whatever it is. But you usually started at half the rate that it was previously. It should say that somewhere. Restart insulin infusion. Usually you restart it at half the rate to avoid if their sugar was like 60, now it's back up to 200 or 250 because you gave them dextrose. Let's say the rate when you shut it off was 5. To be safe, you should start it at 2.5, and then every hour, just follow these instructions again. So start it at half, and you just have to have the chart in front of you. That's as simple as that. And you have to, and then anytime their potassium goes below 3.5, you give them potassium. The magnesium goes below like 1.8 or 2, you give them magnesium. The phosphorus goes below like 1.5, give them potassium phosphate. What else? You give them tons of fluid, support their blood pressure, oxygen, hemodynamics, treat nausea. A lot of these patients are super nauseous. They're tachycardic too, so you don't really have to worry about the QT interval as much. That's that. We'll get into these in more detail in more deliberate trainings. So that's the diabetic, that's the DKA, that's the insulin. We're done there. We did the CPAP. I really want to stress that, you have to be careful. You really, really have to be careful. EMTs, I really, really encourage you and AEMTs and paramedics to do a ton more research on pulmonology stuff. I encourage services to do trainings on it or have somebody who's an expert come and do a training for you. I mean, the knowledge is just invaluable. So I don't have, this conversation and this is not meant to be all inclusive. I don't have the time for that, but things to research if you want to do some of your own research and write this down. The mean airway pressure, the driving pressure that delivers oxygen from whatever your device is into the alveoli that actually participates in gas exchange at the alveolar capillary membrane, because that's what oxygenates the blood. So patients with a low SaO2 on a high FiO2 are said to have, they're RZ patients. They have a PF ratio that's like greater than 250 or 300 or something. That's significant. That's significant respiratory impairment. So, like that, those patients are going to become acidotic, and then sometimes they even have to have ECMO or they just die. So you have to understand lung physiology. You have to understand the alveoli. You have to understand the pressure. So you have to research things like mean airway pressure, and then all the things that coincide with that, like driving pressure, PEEP, PPLAP. Sorry, well, yeah, PEEP. Okay, yeah, PEEP, EPAP, IPAP, the peak pressure, the plateau pressure, the peak airway pressure, however you want to phrase it. Please do some research on that stuff. And then understand the conclusion of this is to understand that just because somebody's maybe has these findings doesn't mean that they meet this. And then likewise, they meet this, but they don't quite have one of these, but maybe they don't need to. You can still validate, like, a COPD. They have this, but their oxygen's 91%, so they don't technically fall under this, but that their normal baseline SpO2 is 88 to 92. That's an example of where this isn't a hard and fast number. And that's also an example of why CPAP is not as simple as just considering an EMT level thing. EMTs are more than capable, but we have to understand a little bit more than just like black and white cookie cutter textbook medicine. And that being said, please don't get into a thinking trap where you're like, I can do this now. I don't have to call in paramedic. If anything that I said in this conversation so far has confused you, or something that you're not super knowledgeable about, or something that you couldn't apply at the paramedic level yourself, then you need a paramedic. If you understand everything that I said and you can even teach me something that's how much you understand about it, then you should go to paramedic school. Anyways, moving on. Double sequential defibrillation. This is kind of funny because I had applied for a waiver kind of sort of for this. And I'll tell you why. I'm going to deliver some of my own opinions, and by no means am I telling you this is not Barrytown says. This is not Mickey says. This is just what makes sense to me. And so refractory VFib, tachycardia after 3 unsuccessful shocks, and a defibrillator is available. So I had done a bunch of QA/QIs, and I've found that like 4 or 5 of them since last summer were refractory VFib. And there's only a few patient populations that should actually have this, like electrocutions, maybe drownings, and then the big one is hypothermic patients. They might be in refractory VFib for a while. You don't want to dual sequential a hypothermic patient that's in refractory VFib because you need to warm them first. So getting them out of VFib is not really the priority. Warming them does that, and warming them leads to a neurological outcome that's survivable. Just shocking them really doesn't do anything for their core body temperature, so they could still, and it still might not even work. The biggest thing about this is vector changes, which I don't think people do. And then also there's no way to assess pre-hospitally, because if the patient just dies, how correct your pad placement actually was. So maybe we've been doing suboptimal pad placements and didn't really notice it, but the idea is to get as much of the heart transected as you can and the largest part of the muscle. You don't know because you don't have an ultrasound or you can't do a transthoracic echo. So you don't know if the atria is involved, the ventricles are involved, or both. So you really don't know which part of the heart you want to target, but I will say there's been a lot of research where the anterior posterior pad placements have had higher occurrences of restoration of the rhythm. And that's especially true with patients that are in AFib, A-flutter. But you have to place the pads correctly. And then in my opinion, if you're thinking about, like, it's like I keep saying, if it's not working, do something else. If it's not working, do something else. Or maybe you're doing the right thing, but you're doing it wrong. So And then you're trying to obviously shock them at the same time. So here's the deal. I'm going to show you my protocol proposal because I worked kind of hard on it. We encounter most cardiac arrest by call volume, Central Vermont. Okay, whatever. That's not really important for this. An observation during the 2024 call years demonstrated refractory ventricular fibrillation with traditional defibrillation, antiarrhythmic drugs, magnesium, calcium, and sodium bicarbonate, as applicable following CDMS protocol and American Heart Association recommendations. It's worth noting that we are unique because we have multiple ambulances, multiple personnel. We're not working a mega code by 2 people. We have backup crews, multiple 24-hour ambulances, auto pulses, and transport ventilators, which free up hands. So some of this can get done faster. We do mega code training, but it's like, if you have 6 people there, do you really need to wait to minute 8 to intubate the patient if you suspect that hypoxia is the H and T, one of the H's and T's that contributed to the arrest? No, you should intubate immediately. If you have the people, like if you have enough people to do CPR, apply the auto pulse, establish IV-IO access, administer an antiarrhythmic, epinephrine as applicable, bag the patient, put in an adjunct, try to oxygenate them as best you can, and then put in an advanced airway, then you should do that. If you're going to transport somebody with ROSC, certainly an endotracheal tube is the best airway protection device, and it allows you to track the end tidal better. But in like the initial arrest setting, a king or not a combi tube, you can't use dual lumen stuff anymore. An iGel are probably just as effective. You have to make sure that you assess them to make sure that they're actually providing ventilation. So that means you need to observe for chest rise or assess breath sounds, actually both. And then also put the patient on inline end tidal. So you need an AMT for that. And if your patient's that sick, then they should probably have a paramedic there. So, we're all capable, but the highest level does the highest amount of good. And the more people you can have tackling the patient at the same time, speeds up the process, also a good thing. So here we go. Yeah, so we're going to do a lot of troubleshooting mechanisms, not just 1, not just 2, not just 3. I'm kind of thinking this is like a series of interventions. So here's what it is. AP placement. This just has to be somewhere on the back, but this does have to be to the left-ish of the sternum. Can't be over here. Because if you apply your second set of pads, the other one needs to go there. So they can't overlap. Sometimes if this is too far over, and it's actually like getting onto the left side of the nipple line, the mid-axillary line, then you're not getting a large enough slice of the heart. It might not be effective. Likewise, sometimes people don't place these correctly. It's got to be the mid-axillary line. People sometimes place them over here. So now here to here also only transects the superficial, the anterior portion of the heart, not the actual middle of the heart where all the muscle is. Here's another example of dual sequential. All right, so let's get into why I said this. You arrive on scene, you start doing compressions, you get out of BVM, you apply the monitor. What in our service, we have the auto pulse, and a lot of other services do too. What do you have to do to put somebody on an auto pulse? You have to pick them up, which means the back is exposed, which means if you are ever going to put a posterior pad on somebody, that is the time to do it. So your patient lifts up, you slide the auto pulse, get ready. If they have a shirt on, you lift it, and you go kaplamp. If they're a really, really hairy person and they're an adult, just take your pediatric pads. Chances are they're going to expire and you're going to throw them away anyways, and just give them a quick wax job with those. Just put it on and rip it off. And then, so you pick your patient up, you put the posterior pad on, you lay them on the auto pulse, you put the anterior pad on, you get the band going. Now you have pads placed and you have the patient on the auto pulse. We're assuming, and another thing is get your patient to a place where you can access them appropriately. If the patient's family called 911 because they've been down for 5 minutes and then it takes you 10 minutes to get there, then another 5 minutes to get all your stuff set up because you have to walk up 3 sets of stairs, you are at 15 to 20 minutes of cardiac arrest. 30 seconds or a minute to optimize your environment to lead to a successful code management is worth it. If somebody was going to die at 20 minutes and 30 seconds versus 20 minutes and 15 seconds, they were going to die anyways. So just dedicate the initial 30 seconds, 60 seconds, even if it's 2 minutes, however long it is. Like, you have to do what you have to do. You have to get the patient into a place where you can access both sides of them, ideally, to swap out compressors and manage the airway, and get your equipment inside the room. If they're folded up against a bathroom door, or a sink or something, or a tub, then you have to move them. I had a cardiac arrest on a waterbed. That's like the worst place you could. I never imagined in my EMS career that I would ever have that happen on a waterbed. So now you have anterior, posterior pads placed. You shock the patient. Let's say you get a first-time successful conversion of the rhythm. One of the issues with having traditional pace placement is that this interferes, and a lot of the times people place it up a little bit more. This interferes with appropriate lead placement for a lot of the times V4 through V6, or even all the precordial leads. Granted, this might interfere with V1, V2 a little bit. Maybe you could put it up a little bit higher. But if you do get ROSC or a conversion in the rhythm, then that's not PEA, then your ability to do a 12 lead is a lot better with anterior posterior pad placement. So that is another added benefit. You shock them, and theoretically, you can shock somebody if they're in VFib. I mean, not even theoretically, this is what you should do. Immediately shock them, because you have the auto pulse, you're doing compressions. This isn't like bystander CPR or like bystander BLS, where you're like, you go get it, and it's an unwitnessed thing, so you have to do 2 full minutes of compressions. You see a lethal rhythm, you restore the lethal rhythm, because the lethal rhythm is part of the thing that breaks the chain of survival. So you shock them. Now maybe it's been a minute. 2 minutes later, you shock them again. They're still in VFib. Guess what? Grab another set of pads. Vector change. And hopefully by this point, your partner's working on, maybe you're bagging. Maybe you just put in a King Airway to make it easy, so you don't have to do a mask seal, which takes up a hand. And hopefully, your auto pulse is going if you have one. And it's been 3 minutes, and now you get an IO IV. IV is obviously preferred. The new protocols will talk about that. And it's minute 3. You give epi. We're not just standardly giving everybody a liter of fluid anymore. A liter of fluid comes from one of the H's and T's, which, by the way, should be applied at the beginning of the cardiac arrest, not at minute 20, where somebody's like, all right, it's at minute 20. Any H's and T's? No, those are the reversible causes of cardiac arrest, specifically asystole. Why would you wait to do a reversible cause until the end? That would be like going to a drowning patient and then waiting 20 minutes to take them out of the water. So anyways, H's and T's first. That's, you do CPR, you start the IV, the epi, the bagging, the oxygenation. You consider H's and T's at the beginning of the code, not at the end. And then intubate them if you suspect hypoxia. And you give a round of epi, and then you place your second set of pads. You deliver another shock. Theoretically, 4 to 5 minutes into this cardiac arrest, you would already had given amiodarone, 300 milligrams, a round of epi, ventilated the patient. Maybe you're considering intubation if you have the resources. You don't have to wait until after minute 8. That's only if you don't have the resources. High performance CPR then becomes the goal. And you've delivered 3 shocks. And then maybe you deliver another one, and maybe instead of, you could always do 150 milligrams of amiodarone as your second antiarrhythmic, but you could also consider MAG. I wouldn't put MAG above amiodarone, because the American Heart Association does place it first. It says magnesium's a third line, but I don't think magnesium is going to hurt. I've never heard of somebody going into cardiac arrest from hypermagnesemia. A lot of alcoholic patients with poor nutrition, patients on like defetalide and a lot of other cardiac medications can have substantially prolonged QTs, and magnesium helps to mitigate that. And sometimes calcium does too. But magnesium is the authorized, according to the American Heart Association, antiarrhythmic to give third line. So amiodarone, then lidocaine. And suppose you could always give lidocaine first, but I've seen better, and I don't have any evidence to back this up, but I've seen better conversion in front of my eyeballs with amiodarone. So this is just saying that we want to consider changing stuff. Start with an AP placement because putting the auto pulse might be the only time, and it's definitely the best time that you can get to the back. You wouldn't want to take the auto pulse off, then lift them up, and then apply a posterior placement. You'd interrupt compressions from doing that. So your time to place AP pad placement, which according to the new protocol, you can start with AP pad placement, is at the start of the cardiac arrest. Shock them once or twice like that. Place your second set of pads, give them epinephrine and an antiarrhythmic, shock them once or twice like that, give them magnesium. Now, by this point, hopefully you have an airway established. Your other crew shows up. They have their monitor. They just plug it in the pads that are already there, and then they dual or double sequential. If you want to read this, you can. I'll kind of just scroll through again. You can pause the video if you want to. Boop, 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 boop. So yeah, well, I'll keep talking while I do this. So that's kind of the gist, I think, of everything that I wanted to talk about. I can go a little faster. There's that. Feel free to pause. There's that. Feel free to pause. Here we go. Here we go. So this is just sort of a way that you can incorporate this while not just limiting yourself to standard or double sequential, but also just going down this sort of more kind of, you're thinking of more stuff. And when you think of more stuff, then you have a less chance of missing something. And you're more well-rounded, more polished. You're probably more calm. When you don't know what to do and stuff's not working, then you get tunnel vision. You get focused on your one task that you're doing. You get stressed. You get frustrated with the people around you. I'm guilty of that too. So having more tools in your toolbox will help you stay composed and think of more stuff. Because if something's not working, like I said before, you got to do something else. Maybe they need a little bit more time, or you're doing your current intervention wrong. Maybe you intubated the esophagus by accident. So that's really all I wanted to talk about. And then my DKA stuff. I had a patient recently where I think they just needed more fluids. I chose to increase the rate of their D5 half normal. I should have just bolused them. My thinking was a little flawed, but in the moment I didn't really recognize it. So self-reflection. Hopefully everybody does this. My thought was like hyperchloremia, which can cause acidosis. But DKA patients specifically can tolerate very high levels of acidosis. That's a patient that you don't want to intubate if you don't have to, because and then this is like the one subset of patients where their pH could be 6.8, 6.9, and they're still awake and talking to you, albeit they're probably miserable and they look sick. You don't give these patients bicarb. Aseptic patients that is totally obtunded and they have hypotension that's refractory from multiple vasopressors and their pH is 6.9, 6.8, they might need bicarb just to get the contractility to even have the medication work. They might be so acidotic the medication, like the present, you give them bicarb and then the actual functionality of the vasopressors increases. But that same logic doesn't apply to DKA patients. They have pHs of 6.8, 6.9 all the time. You don't want to give them bicarb because they're going to be on a DKA protocol, which means that they're probably going to be fixed within 4 to 12 hours on average. And then once you do that, they're then going to be alkalotic, and severe alkalosis has a higher 30-day mortality rate in the ICU setting than significant acidosis does. So that's kind of it. Tidbits of the day. I don't think there's anything else I want to talk about. Okay, we still have to do, we're going to do a DKA deliberate training because of my observations. It's even some improvements that I could have made. We still have to do the cyanide toxicity, some aspirin toxicity. I want to do more critical care stuff. Research season's coming up. Still got a handful of people left to do. let's see, what else are we going to talk about? Case reviews for Addie's call. Ooh, crap. Maybe I wasn't supposed to say that. Everybody probably knows at this point. The cyanide toxicity, that's all due in 12 days now, 10 days, 11 days. And then that's it. Anybody who wants to do a topic, or if they want to talk about any of those things, if somebody wants to talk about CPAP and do that whole training, knock yourself out. I encourage you to get I'm encouraging a better understanding from the EMT and AEMT community. And then I'm also encouraging more involvement in higher level education for the critical care paramedics. That way everybody gets better. And then the EMT, AEMT paramedics understand better what we're doing, because we're not just reserving the good detail for the critical care community. We're sort of learning, like I want to bridge the gaps in knowledge at all levels. I want, explain things where they're easily digestible and not where you're just doing rote memorization like you did in your initial education program, but actually understand. That requires time, effort, dedication to review, and then talking about your calls with people and then figuring out what they would have done. And if you don't understand why they didn't do or why they did what they did, that means that you have to look it up or ask somebody and do more research. So I don't have enough time. There's none, we're too busy of a service to do this, for me to go up to everybody and be like, hey, what can you work on? So seriously, please, if you have any issues or desire to practice more on something, I'll try my best. But if you really want to practice on it, then I encourage you to do the research and get better on it on your own if you can, or seek out a mentor. And then, since you had questions or you wanted proficiency training at something, that means other people probably do, then help me organize a training and then teach people what you learned about the topic that you were previously unsure of. That will solidify it better for you. And then that'll also help give the information to people who also probably had the same concern or need for practice or desire for improvement that you did. That's all I have. Okay, thank you so much once again. I'll do another one of these probably in a few weeks.